2, 1. Oh,
I don't even know. It says
Oh, yeah.
preparing. I think we're on live already. So welcome, everyone. This is live, and we are with Dr. Ari Baratz from Create Fertility in Toronto. Oh, shoot. Okay, I gotta wait. Sorry, I had to decrease the sound because I'm hearing it from both ends. But we are totally being live streamed right now on YouTube. So this is the second time we've ever been doing it. Super exciting, and this will have people get more access to your words of wisdom. And today's topic, I think we just had this conversation, Dr. Baratz, about how, the buzzword is like, how to do everything naturally. And when it comes to IVF, are there things that we can do more naturally when you go to the fertility clinic? So I'm just going to basically like pass on the mic to you so you can just chime in.
Well, that's a little bit of pressure there because you're the host, but I'm happy to have a conversation with the theme of all things natural. I mean, obviously, I'm sitting here with a white coat and surgical scrubs. That's not a very natural look, but there's definitely a move to trying to embrace natural aspects of human reproduction and fertility in managing infertility cases, and so. And there are many, many examples of it. And so, I'm happy to sort of run through some of the hot topics. I would say the one that is probably most interesting is the idea of frozen embryo transfer or embryo transfer. So I just sort of spoiled it a little bit by saying frozen embryo transfer, which is not a very natural process. And embryo transfer to begin with is not a very natural process. These are all underpinned by quite artificial systems, right? We build embryos in a laboratory. That's, even the title of IVF is in vitro, in glass. So artificial, not natural. But is it possible that there are ways to reunite people that are trying to either build their families, conceive, use artificial technology, and reunite them with some natural components? And that may be out of choice, or it may be due to a medical issue, or as we're going to probably learn by the end of this year, there actually may be even evidence that certain natural protocols are par and maybe even superior to what we used to think of as the standard protocol for embryo transfer. So a bit by way of background, embryo transfer requires synchronizing an embryo, whether it's fresh or frozen, with the host, with the recipient parent, individual, surrogate, whomever that is. And we know that in recent years, there's been a big push and move and shift, not just locally, nationally, internationally, to frozen embryo transfer, elective frozen embryo transfer. And maybe you could comment on that, Mary, like what percentage of your clients and patients are part of a frozen embryo transfer as opposed to a fresh embryo transfer?
Oh my goodness. In my own personal population of patients, I would say well over 90%.
Yeah, I would say that in my practice as well, like way more than 50%. So I would say the majority nationally, it's probably about an 80 to 90% elective frozen embryo transfer rate. And so when you start doing that, you start asking questions about, first of all, is freezing an embryo safe? What are the success rates? And I think we've talked about that in the past, how the advances in embryo freezing have allowed us to very comfortably offer that as a technology. But the part that still remains a challenge is that whole implantation window, right? Should that implantation window be done with a mixture of hormones, like what we call a programmed cycle with estrogen followed by progesterone? Should it be done in the context of downregulation with medications like Lupron? Or should we take advantage of the natural cycle in ovulatory women who release eggs on a regular basis, and try and synchronize their cycle with the embryo? And that's what we call natural cycle frozen embryo transfer. And the idea is we are using a woman's own hormone production and that her own sequence, and then bringing the embryo up to speed with her cycle. So in theory, sounds great. More natural, less exposure to hormones. In practicality, there are some challenges. I guess challenge number one is you have to ovulate. So a lot of our patients that we share, Mary, don't ovulate, right?
Mhm.
So if they're not ovulating, it's okay if they're ovulating irregularly, but if they're not ovulating at all, then we have to find a way to make them ovulate. And they'll essentially fall into one of two categories. Either we can induce ovulation with medications, so we're now moving away from the natural because we're giving them drugs, but they're usually lower level medications. So these are drugs like letrozole or clomiphene, or the injectable drugs they used for their IVF to get them to ovulate, or they just aren't a candidate for natural cycle frozen embryo transfer. I mean, if they're menopausal, or are perimenopausal, or have ovarian insufficiency or ovarian failure, it may not just be practical. So I don't want to oversell the option, but it certainly is an opportunity for couples, individuals that are looking to reduce or remove or decant the medicalization of their process.
And I think it's really important, if I may jump in there.
Yeah.
And, we also have to look at people's lives, right? So personally for me, of course, the romantic notion of let's try to do an embryo transfer more naturally, let's minimize drugs and that protocol. But from a practical point of view, as an acupuncturist, like, even though in my heart, I'm like, I would prefer the natural, I ended up choosing not to do natural, which was shocking to myself. And that was purely out of, practicality. It's like, how am I going to figure out exactly when I'm going to ovulate and then be away from my patients, right? So this made it more practical.
So that was the second. So I said there was like two limitations. So one of them would be on the patient side in terms of the physiology, and number two would be on the clinic side and the patient side in terms of availability. So programming on the natural side is quite challenging, right? Because you're visiting the clinic more frequently. It's uncertain. It's not guaranteed that we'll be able to capture the ovulation window. And also, if you live further away from a clinic, if you have to travel a distance, if you have a busy life or job or other commitments, it may not work. So it's not the perfect fit for everyone. It isn't the starting point for everyone. You also have to have a certain sized clinic to be able to support that kind, because you also have you have to have a 7-day-a-week clinic, because there may be surges or ovulations that occur on weekends. So yes, there are some program-based challenges. So typically, natural cycle frozen embryo transfer is offered to women who have some risk at hormone exposure. So those women, we would say we should do that. Women who have maybe failed traditional programmed cycles, or on request. I mean, that would be the option. But what I was going to get at, though, is that right now it's a coin toss. Like we say to people, you could go with the hormone-based, you can go with the natural cycle. And just to clarify, when I say natural cycle, I should really say ovulatory cycle, because whether it's natural or we use medications to create ovulation, some kind of ovulation. And so what I was going to say is that it is a coin toss. Like we sort of say to people, you can go this way or that way. It's an option. But I think what we're going to learn, there's a large study going on in the US, and I believe it's through the NIH, that's randomizing recipient women to either a programmed or a natural cycle, large group of women. I don't have any numbers, but that will at least show us which is, if they're par, if they're equal, and maybe if one is superior. So that'd be really interesting.
Oh, shoot.
That's okay. Little dog behind you. Are you still on?
I'm on. I just wanted to put myself on mute so you can talk.
No problem.
more.
No problem. So that will be interesting. The whole idea of supporting frozen embryo transfer is going in two very wide directions, because on one hand, there's this whole move to explore add-on medications, extra drugs, receptivity testing, ERA, like building it up and up and up. Hey there. But it's okay. But when you think about natural cycle, you're kind of moving the other direction, right? That's okay. Is that your dog?
Yes, sorry, that's my dog.
That's okay.
Yeah. Okay. Now we're back in business.
Yeah.
Sorry,
So that's fine. That's fine. So natural cycle sort of moves in the other direction. But I think it's also quite attractive in people who are maybe dealing with secondary infertility. So people who have demonstrated a live birth before, or have had pregnancies in different circumstances. And so there, what we're doing is we're exploiting what they can do really well. They can implant, they just need the right embryo. So I think there's certainly certain groups, people have, let's say, mechanical based infertility, like blocked fallopian tubes, or let's say obstructive male causes like vasectomy. So these are people that just need the IVF to bypass the mechanical barriers, and it may be an opportunity to make their process a little more natural.
I love that. And so when we say a little more natural, and you pointed to it earlier in terms of naturally occurring ovulation, but really it's not completely natural, because basically after the into the luteal phase, or after ovulation, you're still using drugs.
Not necessarily.
Is that right?
Yeah. So
no progesterone?
So the big gap. So when we talk about ovulation, we talk about an event that occurs physiologically where there's a surge in hormones and then a release of progesterone coupled with a whole bunch of other hormones. So when we do programmed or hormone-based frozen embryo transfer, we are giving back those main hormones in the form of estrogen and progesterone, sequencing them such that it mimics what the body would do, growing the lining with estrogen, making it more receptive with progesterone. But we're not really giving that many more hormones than that, right? Those are the main ones.
Right.
But in the body, when ovulation occurs, there are a whole slew of hormones that are released in different quantities that you miss out on, including progesterone and estrogen and others. And so steroids, a whole bunch of hormones. And so that's what's believed to be some of the benefit of the natural cycle frozen embryo transfers. You're tapping in to that natural hormone source that, in fact, when you do a hormone-based frozen embryo transfer, you are suppressing. You're not ovulating in those hormone cycles. So, and furthermore, the other theory that is being put forward is that when we have patients, and I'm doing this more and more now, I've been interested in the last year or so, we have patients that, and you've probably seen them too, Mary, that we do a great job of getting them pregnant, but then they have very complicated pregnancies. They have problems with blood pressure in pregnancy. They have placental problems, abruption, maybe a small baby, placenta previa, a whole slew of obstetrical problems. There is some data and some theory that suggests that if we can preserve that corpus luteum, that's part of the natural cycle frozen embryo transfer, that we can minimize those weaker or those poor obstetrical outcomes. So I'm actually, when I identify any patient that has had a rougher go with their pregnancy, I try and convince them or suggest to them that the frozen embryo transfer may be part of the solution. So you start by saying we give them hormones. We don't have to give them hormones, because they're actually at our Canadian meeting a few years ago, there were some abstracts and now papers that have shown that as long as you can demonstrate ovulation, you don't even have to give progesterone back.
Which I love, but when I see it in clinic, in terms of the patients that I see, even when they're doing this modified natural, I'll call it, they're still getting the progesterone. So what is your take? Are you now doing it that way, where you're not even supplementing the progesterone?
Well, so it's always, when you're trying to make a case, it's always good to use case examples. So there are people out there that have hypersensitivity or maybe even allergy to progesterone. And it's hard to understand, but there are some people that are very sensitive to progesterone supplementation. But yet we know they need some level of progesterone. And so those are women that I'll just say, let's try this without progesterone. And we see lots and lots of pregnancies. Now, again, we might be really good at getting them pregnant, but they may have a loss, right? They may have a miscarriage or an abnormal pregnancy. So we may have to look at alternative progesterone sources. So there still might be some supplementation, but it isn't wrong to offer them a completely natural cycle.
Awesome. I love that. Thank you for sharing this, because I think this is very insightful, and it will, lead people down a different path, I think, of what they think that it would have to look like.
Well, look, we all have an element of, we're all a bit sentimental, a little bit superstitious, and we all want to do things that we've been doing it for the last 15, 20 years, and or even longer, at least in my career. I haven't been doing it for that long, but progesterone is definitely like my friend. Like, it's been a big part of it's in my tool chest. It's been a part of the hormone set that I use on a regular basis, but we're learning that you don't always have to use it.
That's great.
Right?
Wow.
So, yeah, I mean, if you think about it, like 95% of pregnancies are not hormone based, and those are all ovulations, and like those are most of the pregnancies in Canada. I mean, it would be different if we were doing a fresh transfer. Like in a fresh transfer, there are certain suppressive maneuvers that we use with our drugs, and so you perhaps may need to add back hormone.
Right.
But in a frozen transfer where you're producing ovulation, you're endogenously giving people their hormone, so you don't actually need any extra hormone.
So what percentage of your patients currently are doing the natural FET?
It's a great question. I would say that we're kind of running around about a third. We have some patients that live further away and it may not be as practical for them. Also, about a third of our patients have severe ovulatory problems and it just doesn't work very well with them. But I would say about a third are opting for so that's another question, is elective natural frozen embryo transfer versus someone who we roll into it after a few failed transfers. So elective natural cycle frozen embryo transfer, I think we have to look at our data for the last year and see, but I think it's about a third of patients.
Wow. So that's great. That's much higher than it used to be, for sure. And
Yeah.
so just out of your clinical observation, I mean, rather than just looking towards research that is out there already, what have you seen any positivity, like, in terms of swaying pregnancy rates, not just pregnancy rates or outcomes, but also live birth rates? Have you seen any differences?
Right. So that's exactly it. So all the data up until this year has not been randomized. It's been cohort or retrospective data. Because people have toyed with natural cycle for a while,
yes,
for all the reasons we mentioned. But it'll be, I believe, by the end of this year, in fertility and sterility, there will be publication of the results of this random. I don't know the title of the study, but it is a randomized control trial looking at natural and or ovulatory induction cycles versus hormone. So we're just waiting for it, and maybe you'll invite me back when it's back out and we can discuss the data. I mean, we may find out some sobering thoughts, but I mean, all the cohort data and prospective data so far looks pretty good. And so I guess once you randomize people, because there's a lot of bias, right? Like maybe
of course
you have some feeling, but once we see that RCT, I think that will help us counsel people more effectively.
But even still, without the retrospective studies, in your clinic and what you have done so far, do you think that it has increased rates, or you just don't want to comment?
Well, I think it's all anecdote at this point, but I mean, what I am seeing is patients who we struggle to thicken their lining appropriately, or we've placed euploid embryos and they haven't gone pregnant. And then we look at what else is available. And so we pivot towards natural cycle and they get pregnant. So that's not really data, that's just experience.
Yes.
But when that experience replicates itself, and it's reproducible, you then start to make an argument. So we're not in a position to have a randomized control data, but I certainly will, once that is available, I'll be able to share that with my patients and with the greater community. But what I am seeing, though, anecdotally, is people are doing as well. I can't say better or worse, but if the status quo was negative pregnancy test, then anything I can offer them to get them pregnant, I will try, or we'll at least engage. And we've seen improvements.
So this is very interesting, because what I find is that, when a woman has a negative or a failed frozen embryo transfer cycle, the tendencies towards, maybe there's other things wrong and maybe we need to look at autoimmune component, versus maybe the body just didn't do as well with drugs as it does with your natural cycle. So I think that's very interesting that you pointed to this. And
well, it speaks to the whole space of receptivity and implantation windows, which the belief is, I mean, that's what the ERA group wants us to believe, which is that with evidence, you can show that someone's window, like if you take 100 different women, they're not going to all have the same window. But when you do hormone-based transfers, that's essentially what you're saying. You're saying that, like at least in our clinic, the standard would be usually on the 6th day of progesterone to do the transfer. And so you're saying that all the women that come through, that's their window. But it may not be that. It may not be that case. I think that the window is probably a lot wider than what the ERA people would like to argue, that it comes down to just a narrow couple of hours. Problem is, we're not standing there with a camera watching exactly when implantation occurs. We know that embryos can implant anywhere from day 3 to day 5. I mean, there's a wide range of implantation windows. So it may just be that it just wasn't the right cycle, or there may be something that we can influence. And that's the challenge, is how much tinkering are we going to do? If you keep tinkering, then you're adding another variable into the process.
Yeah. And I think it's easy to fall into the trap. And I know this because I've been through it personally, where when it doesn't work out, you just start looking at yourself, there's something wrong. You pathologize more and more versus actually looking at, what's possible. What can we perhaps less is more, right?
Right. Well, there's some other supporting. It's a really good point that you make, because less is more would suggest you're already doing more. I mean, you're already doing IVF, you're already doing transfers, but and this is what we struggle with, which is, if, let's say we fail transfer 1, we fail transfer 2. If we keep doing the same thing, this is the question we ask. If we keep doing the same thing, is the next move more likely to work or less likely to work without a change? That's the classic question we run into, whatever the change is. And there are other paper sets coming out, research groups, especially in the US, showing that if you have normal embryos and you give someone at least 3 transfers with the same protocol, no adjustments, you can achieve very impressive pregnancy rates depending on the unit, right? Pregnancy rates as high as 70 to 80% with normal embryos in some groups. And that's just by using the same approach. So what that suggests to us is that maybe there's an embryo issue, maybe there's a uterus issue from month to month. But if you allow exposure, if you throw the ball at the target enough times, in most people, you should have a hit. Like, meaning this whole concept of recurrent implantation failure with a clinical diagnosis is really putting into question, is probably not as common as we think it is. Some would argue that it's as high as 10 to 20% have recurrent implantation failure. And you see a lot of clients that are complaining of that. But it could be that they just haven't been given enough opportunities. There are some, yeah, go ahead, sorry.
Well, my pointing towards is that, again, not necessarily normal, normal, oh my goodness, chromosomally normal PGTA tested embryos does not necessarily equate to a baby.
No, it doesn't.
Right. And we need to kind of, highlight that piece as well, because again, when a woman gets pregnant or doesn't get pregnant, or they miscarry with that, they automatically go to, there's something wrong with me.
Right. But so to take that point further, but having PGTA normal embryos transferred in subsequent cycles, like month 1 and month 2, and having negatives does not mean that the third one's not going to work.
Right.
Oh,
yeah.
Tanya's joining us.
Yes, Tanya's joining us. She was in the midst of working as well. So she just wanted to get in last minute, but
okay.
You've missed a lot. We're not going to talk again about this, but it's just so insightful. Before we drop off, what is your biggest advice then? Because this topic in of itself can be confusing. What do I do, right? Yeah. If I'm in that boat?
Well, I guess my biggest advice would be to try your best to not grasp at straws, like to look at what you have, not what you don't have, and engage your team in a meaningful way so that expectations are properly set. And that way, if it doesn't work, we were all prepared for it. And if it does work, we're all prepared for that as well. I think that's really my one take home is, as long as we can set realistic expectations and we understand that we're not working with a perfect science, people will be able to get to that point where they've given it their best shot, or we need to make other changes. But the idea of changing or exiting treatment very early on, just because we had, one failure, easier for me to say because I'm the one that has to keep doing it and I'm not, on the patient side. But I very often see that frustration is driving next step when it really should be a clear head.
Yes.
Subscribing to appropriate providers and setting realistic expectations. So that's my advice. Because, we just spent time talking about an alternative transfer protocol that is cheap, easy, and effective. And it doesn't involve months and months of testing and retesting,
Yes.
and spending extra money on top of what's already been spent in extra emotion. So that's all.
No, it's not. That's all. I think it's really, really wise. And it
Yeah.
goes back to, we need to be a part of the equation again. And I think what women, when you kind of lose your sense of, um, what's the word? Like you're disempowered, you're anxious, and you feel at a loss and desperate. And when you're in that place, you make not necessarily the best choices. And coming out of desperation, like then you just kind of follow whatever the protocol that may be, or advocate not necessarily that's in your own best interest, right? Because there's lack of when you have that lack of self-esteem,
I guess what I'm saying is very often, either on the provider side or on the patient side, one of the phrases I hear, and it's such a deserving phrase. They say, "I can't believe it didn't work."
Right.
And I think to myself, I mean, I wish I could take that position. Like, I wish it was 100% pregnancy rate and that I could actually say to someone, "I can't believe it didn't work." But what's probably more appropriate to say is, "I'm disappointed that didn't work. I wish it would have worked." Right. But when you say, "I can't believe it didn't work," what it's saying is that it had a 110% chance of working, and that the fact that it didn't work is a very atypical outcome. And that's not the case. And so that's an example of a gap of knowledge, a gap of expectation that needs to be set early on. So I tell patients all the time, and it's not, I'm their biggest cheerleader. I would love for them to, it's not meant to be self-serving. I don't want to have to do more work than I need to achieve the job. I mean, our mandate is live, healthy birth in the shortest amount of time. But I tell people, if you get pregnant off the first transfer, we are ahead of schedule. This was an exceptional outcome. But prepare for 2 or 3 transfers, and if you're pregnant off the first or the second, then amazing. You're far ahead. And that's when I would say things like, "I can't believe it worked so quickly."
Right.
But to say, "I can't believe it didn't work after one failed transfer," it's just the wrong phrase. It is not a self-serving phrase, and it sets you up for a very defeatist attitude. Sorry, Tanya. Is it Tanya or Tanya?
Tanya, thank
Tanya.
you.
Sorry.
No worries. I was going to say that the way I look at it is, when you're doing IVF, you're narrowing down your time of trying into one go from, let's say, a 12-month process. Like, let's say if you're lucky, you're getting 12 eggs, and you're perhaps have 3 at the end if you're lucky to transfer. And if the first 2 don't get transferred or aren't successful, those 2 transfers, then you have a higher chance with a 3rd. So rather than, because it's all about like the batch, right? Like, isn't there a higher chance after?
Yeah, we refer to that as cumulative pregnancy rate. Right. So cumulative pregnancy rate is the stat that we're most interested in. We don't,
right,
yeah.
We can't deny, because this whole thing is an emotional journey as well. We can't just isolate it to this linear journey, right? So that's what people are coming from, right? So I get like when they say, "I can't believe it didn't work out," it's really coming through their emotions, because yep. What was underlying is like, it has to work out because I don't even know if I can endure this any longer.
Right. So yeah, I'm fully acknowledging that each movement takes more and more energy, and that's the problem. Is that even to Tanya's point, even though you're closer to the end point, the more you do, the harder it is, right? Each step becomes harder and harder and harder. So it's almost like recently I've been watching some of these space shows. Like my kids are watching Beyond All Mankind, or it's a sci-fi space race US. It's on Apple TV. Anyway, like they show them, sometimes they're in space areas where they have no gravity, and they're trying to walk, and each step seems so huge. And so I feel that. I mean, I feel that with my patients, and I feel that as a provider. I mean, the more we do the deliverable, there's more pressure for it to work. That's the other side of it. So we feel the pressure too, but I think there has to also be an element of trust that if we do hit a point where we think, to Tanya's point, the next step is less likely to work, that someone will stand up and say, "I think it's less likely to work." And that's the challenge when you're in an enterprise is there's always this perception that, well, the more you do, the more money you're going to make. And I'd like to feel that the doctors that are involved in this see it the other way, which is the less we do, the more successful we are and the more people we can help.
Agreed. Yeah, thank you. I think every woman that is doing IVF needs to watch this. This is a really enlightening conversation and pertinent one.
And man.
Yes.
Every woman and man.
Yes.
Partners, everyone.
Well, we can they gender neutral. We have to say they.
Every single person.
Every person.
You know, that's another challenging group, which is, you know, we help a lot of people in the LGBT space who are not really infertility patients.
No.
These are people that are stuck in the infertility space, in the fertility clinic, doing fertility promotion. Like they're just trying to get pregnant through these techniques, and they somehow find themselves having these difficult conversations of implantation failure. And I've never tried to get pregnant. Why is it so difficult right now? I've invested in this technology. And so it doesn't matter who I'm meeting. If I'm meeting a same-sex male couple who's using like a young egg donor and a surrogate, which you'd expect would be the highest pregnancy rate on the land, and we still have our challenges. So setting expectations, staying engaged, always looking around, asking the right questions, not over promising, but not under delivering. Those are the big themes that carry me forward.
Thank you for that. And, you know, to add in, I would say, you know, it's important to have your team. So someone like Dr. Baratz, someone like Tanya, a naturopathic doctor, someone like, you know, my associates doing acupuncture, counselors, loved ones, supportive people. And they may not necessarily be in your life. They might be professional help, because a lot of people are very private in their lives. So you just need to round your village.
Okay. So anyway, was there any other question? Or okay,
No,
well, just one last point. We were supposed to talk all about natural. We just talked about natural cycle FET, but there are other topics that fall under natural. And I mean, in fact, Tanya and Mary, you're probably our experts in that. So just optimizing pre-pregnancy. There's a lot of data coming out now avoiding toxins. Like people, I think they minimize environmental exposures a lot. There's huge reports coming out about what the environment's doing to us and our fertility. So there's a lot of pro-nature, and natural-based topics in the clinic, outside the clinic, that can optimize fertility. And don't forget that the first IVF baby was through a natural cycle IVF. So that's a historical piece. So nature is a great topic. It's also good to be out in nature and just going for a walk.
100%.
And that's it. So all things natural, sort of.
Thank you.
As I have the create IVF email on the top of my screen there. Okay. Well, anyway, if you ever want to talk again, Mary and Tanya, I'm more than happy to chat. You both are great. Shout out to both of you. Your patients and clients love you. You're rock stars. And thank you for involving this. It's a huge honor and pleasure.
That's an honor and pleasure for us. And you're literally taking time out of your day, and you need to get back to your patients because we want them to be seen.